Hello and welcome to Deep Dive with KPMG East Africa, where we bring you insights, analysis, and expert opinions on key issues shaping the industry and economies today.
A very big welcome to our audience. My name is Erastus Maina. I am a partner with the KPMG in East Africa, where I co-lead our work within the health sector. I am also a Kofi Annan Fellow in Global Health Leadership. We are running this series of podcasts to talk about issues affecting healthcare delivery in Kenya, in the region, and also in the continent. We've particularly focused on health financing, being one of the key building blocks of a strong health system. And today we are privileged to have a guest who I will let introduce herself because she's in the thick of things, in the thick of health financing. And we are looking forward to hearing from her about the mechanics of health financing and the interesting innovations and developments in this space. I'm very happy to pass it over to Dr. Wangia to introduce herself. And perhaps maybe as you introduce yourself, Dr. Wangia, you can start by introducing also what your role is and what your work entails.
Okay. Thank you very much, Erastus. My name is Dr. Elizabeth Wangia from the Ministry of Health. I'm the Director for Health Financing. I've been in the public service for the last 18 years, but this current role as a Director Health Financing has been held since 2023 April. Prior to that, I was the head of UHC Secretariat. So in the past government administration, and while in the past government administration, UHC was also a priority, and therefore during that time, I also spearheaded the changes under the Big Four. By then it was called the Big Four agenda, but now we call it the bottom-up economic transformation agenda. So it's a whole journey, just like UHC, which is a journey, not a destination.
Yeah, indeed. And you've been quite involved, and I do recall obviously about the Big Four agenda, and it's good to see that the focus on delivering healthcare for all has carried through the transition in the administration, and we are looking forward to hearing a little bit more about what the current administration is doing about it. Maybe just before we dive into the business of the day, what would we find Dr. Wangia doing over the weekend when you're not busy, leading different aspects of the Ministry of Health?
That's a very good question. Dr. Wangia is an introvert, so most of the time you'll get her at home. Especially weekends, I just take time to relax, having spent all of my energy from Monday to Friday. I would sit, watch a movie, take my wine. But when I'm not doing that, I also bike a lot, cycling. I run. I also hike. So when I'm not doing either of those, I'm either somewhere in the mountains or in the hills, hiking or cycling somewhere, or jogging. I'm also a lover of dogs. I have quite a number of dogs. So when I'm also at home in the midst of the movies and just relaxing, bonding with the family, I also play around with my dogs.
Nice. Seems like we share quite a bit in terms of the things that we like, because I also love dogs. At some point I kept 4 dogs. Mm-hmm. Unfortunately, where I've moved now, I'm not able to keep them, but I'm looking forward to also getting into a place where I can keep dogs. And I also used to hike, and it's good obviously for keeping fit and being in good health. So yeah. I think we should talk more about our hobbies after this.
Exactly.
All right. I guess now we can transition into the discussion that we're going to have. And thank you so much for, accepting to be our guest today. I'm sure our audience is looking forward to hearing a lot about what is going on in Kenya in terms of the reforms to make sure that we are delivering healthcare for all. But maybe we can start a little bit broadly, perhaps even go global. As you know, this week, the UN General Assembly has been in full swing. And I'm sure one of the things which is being discussed by the leaders is the progress that we've made towards achieving the Sustainable Development Goals. For us, specifically focusing on Goal 3, about good health and well-being for all, I would like to hear your perspective on where you think we are at, especially now that 2030 is firmly in the horizon. And especially now looking at financing, do you feel globally we've dedicated enough funding to achieving that particular goal, or do you think there are gaps there?
Yeah, so on that, one of the key, goals under the SDGs, as you correctly said, is Goal 3, which is, around health. But then specifically narrowing down to Target 3.8, which talks about attainment of universal health coverage for all. And when you look at universal health coverage, you're talking mainly about access to quality services, issues around equity. And if you look at 3.8.2, really touches around financial protection. So even as a country, and even looking at the Ministry of Health, whose mandate mainly revolves around policy making, capacity building, we align our policies to the global agenda so that whatever commitment is done at global level, then we trickle it down. And not only are we looking at the UN, global commitments, we have even our African-specific commitments. Okay. We have, for instance, the one that is specific. I'll touch on the ones that are specific to health financing. Yeah. So we have the Africa Leadership Meeting commitments, the ALM commitments of 2019, that mainly focus on increasing domestic resources for health. And with that, a lot of our interventions currently, so to speak, are in alignment with those commitments. So we believe that in terms of the interventions, we are on course. But then at the end of the day, we'll need to see have this intervention borne some fruit, because interventions without outcomes, then those are just processes.
Certainly. Certainly. Okay, good to hear that. And obviously remaining global and also maybe narrowing a little bit to Africa. As you said, on health financing, there is a commitment to make sure that we provide adequate funding to meet the healthcare needs of our population. So as far back as 2001, there was a commitment to dedicate at least 15% of the budget or spending, national expenditures to healthcare. And equally, WHO has also said, or rather indicated, that for you to provide adequate basic health care, the per capita spend should be about $86. That figure may have changed over time. Now, looking at the African countries, not just, I know we'll narrow down to Kenya, but just looking at African countries, I think it's only a few who have sort of met that benchmark. What do you think the challenge is towards meeting those commitments, because they are really important in terms of making the other aspects of the healthcare delivery work?
Yeah, so if looking at the African countries, I think over the years or in the past, we have been really heavily dependent on donor funding. And therefore, probably internally, then it's seen as a need that has been met already, and therefore the treasuries also limit their financing to health. And of course, if there is a need that has been met, then therefore the need even to advocate for more resources becomes less and less of a priority. In addition to that, you'd accept or you'd agree that not many African countries do well in terms of even their GDP. Further to that, some of these loans that have been, taken by most of these countries end up reducing even the fiscal space for the country, and therefore, even if you desire to allocate the 15% as declared in the Abuja Declaration, it becomes quite of a challenge. Though over the years, we really want to move away from just looking at that 15% and looking at what is the allocation, what is the health expenditure in terms of, in relation to the GDP. Because that means if a country is doing well, then they should also spend equally proportionately well based on whatever they are producing. So those are some of the areas I look at and see as key challenges. Then, of course, we have issues to do with accountability, lack of data to really inform, prioritization, because without data, you cannot advocate better. And therefore, you have no reason to, in an environment where there are competing priorities, it becomes very difficult. Then not to forget that health is considered, it's not looked at as an income, like an income generator, or I would say an economic, something that could transform the economy. Yet we know that a healthy person healthy population is a more productive population. So we have always been looked at in the health sector as consumers instead of people who can actually contribute to the GDP based on just the fact that people are healthy and they are more productive.
Yeah, which is interesting, because if you look at it, if I'm right now I'm working, right? Mm-hmm. If I'm not well, I will not be able to work, meaning then I'll not be able to earn. And there are people who depend on me. So I think health really plays a very significant role in making sure that we are productive. But I like the comments you've made, and I have two questions related to that. The first one, you've talked about the dependency on donors to sort of supplement or complement the government spending, and sometimes that makes the government maybe reduce on the funding that is dedicated to health because the donors come to fill the gap. Now, there have been some voices recently calling for the revisiting of the current global financing architecture, including the global financing. So the likes of Global Fund, Gavi, GFF, Global Financing Facility, UNITAID, all these have been the mainstay of health delivery in some of the countries where government funding is not adequate. But now there are some voices which are talking about even sunsetting these financing into around 2030. Meaning then there's need for more domestic spending on health, right? So I don't know what your take is in terms of how the current global health financing architecture is. Is it serving its purpose right now? Do you think there are changes which are due? Do you think we are at a point where we should be looking at transitioning to domestic funding?
Yes, I really agree with you, because if you look at I would say the partners you have mentioned, the Gavis, the Global Fund, they actually sat, was it in November 2023 or December, and came up with the Lusaka Declaration. Mm-hmm. Within the Lusaka Declaration, they acknowledged that a lot of what they have been doing is not working, actually. I would say it worked at some point, but it's in a sustainable way, it won't really work for countries. And therefore, there's the call, one, for this whole transitioning, and number two, alignment of priorities. The main thing was around aligning priorities under what we call a one plan, one budget, one monitoring. Mm-hmm. I know many of the, the bilateral, multilaterals have had concerns around the governance issues. Mm-hmm. And therefore, that's why many of them preferred operating, as standalone. But if we are to achieve bigger impact, we have no choice but to put everything on the table and plan together and say, these are all of our resources. Based on these resources, we can prioritize on, these key areas while in agreement. Even in Kenya, we have had quite a number of partners who have given us their exit plans. Like, for instance, Gavi have given us their exit plan. It was up to 2027, but they were gracious to extend it. We were not really ready till 2030. PEFA following, and many other partners. Even Global Fund have indicated that they'll also be transitioning with time. So we have no choice but to realign ourselves and come up with more sustainable mechanisms of financing. If you look at our current reforms, where we have, we are prioritizing health through, of course, the social health insurance with the 3 funds. If you look at those 3 funds, they eventually they will serve that purpose. Like for primary health care, we'll need resources to be pulled as we do the one plan, one budget, one M&D. We pull the resources for primary health care. If there are any primary health care interventions, they be offered through that one pot. And therefore, what this means is that we'll, one, achieve through integration of services, because once you integrate services, you free up a lot of resources because you avoid duplication. Because I can give you an example that we have been having these community health promoters. They were called volunteers before.
Volunteer CHVs.
So this one community health volunteer, someone maybe from a program, say malaria, will come and give them some resources, tell them go and pass this malaria message. The following day, someone from reproductive health tells them go and pass this reproductive health message. Basically, those are inefficient. It's basically inefficient. So once we integrate services, then we become more efficient. So when this, say, community health promoters goes to a household, they can address issues of malaria, they can address issues of sanitation and, basically broad-based issues, and therefore freeing up resources. Sometimes we may assume that all these resources that come to the country need to be replaced. But the reality is that with integration of services, you may realize that you actually need to look for less than what you are receiving to achieve the same outcome. If you think of all the investment in health over the years, the last National Health Account indicated that we spend, our total health expenditure is close to 500 million. Yet, not 500 million, 500 billion, sorry. Yet, we are not seeing much impact in terms of, life expectancy. We have improved over the last 10 years, but you should see, with such investments, you should even see more improvement. We should be seeing improvement in neonatal mortality. It hasn't moved a needle over the last 10 years. Maternal mortality has not improved in Kenya over almost the last 10 years, despite more than 10 years, despite the heavy investment in maternal mortality. Why? Probably it's because of all these disaggregated, investments that don't end up moving any needle. So we are saying if we agree with actually are they called global health initiatives? The Gavis and the global funds. Yes, we totally agree with them because that approach would also help us as a country. We are not saying that it's only them who are disaggregated. Even within the country, using our domestic resources, we are disaggregated. Like for instance, when we reimburse a public facility, if we have done our costing for services, we reimburse a public facility, yet we are still giving them equipment, we are still giving them human resource. That is actually double financing. So if you look at a situation where we'll eventually cost our services very well, you see what is the cost of human resource, what is the cost of equipment, We just need to reimburse the public facilities, and they should be able to cater for their human resource. They should be able to cater for the equipment, because it's the same pot that pays the human resource. It's the same pot buying for them equipment, and it's the same pot reimbursing them at a rate that is close to the private. Yes.
Right. That's a very comprehensive answer. And I think you've gotten into a lot of issues that I really want to dig into. But perhaps so that we leave the global and continental level, I want to echo what you said. Certainly, with the eventual sunsetting of some of these financing mechanisms, I think the African countries are on notice to make sure that they dedicate enough domestic funding into health. I think it's President Kagame who commented a while back that the health of our populations is so strategic that we cannot leave it to external funders to cater for it. And you've mentioned about the Lusaka agenda, which I think Kenya co-chaired. And one of the big shifts which is expected is obviously around better coordination, as you said, because right now maybe there are a lot of inefficiencies. So now coming home, and I'm excited to have you here, because right now I think if there's a topical issue in Kenya, it's about the reforms which are happening within the health sector. Our audience would like to hear, in your own words, how would you describe the current legal policy reforms, and how are they geared to making sure that the healthcare is available to all Kenyans without getting into catastrophic expenditure?
Yeah, so it's indeed an interesting time to live in Kenya. One, I would say specifically because of all the years, this is one of the times we can say that we have had the greatest political buy-in. In the previous administration, yes, UHC was an agenda. And to us, that is one thing that you cannot buy or get from easily, because many countries have had clear policies, clear, legislative framework. But when you don't have that political buy-in, it becomes very difficult. So it's an interesting time because of that. In addition, all these reforms, would consider them quite ambitious, so to speak, because there are a lot of changes happening at the same time. These changes actually are based on, I would call them 5 pillars. So we are looking at, because they all surround health financing. So looking at commodities. Commodities are the greatest cost drivers when it comes to health. I would say, put it at 60 to 70% of expenditure within health is actually around commodities. And therefore, if you don't have a strategy around commodity, it doesn't matter how well you finance the system, you will still be buying expensive commodities. And therefore, on our end, we are looking at how do we enhance the commodities, make sure we get affordable commodities, and even encourage local manufacturing. For the local manufacturing, even if they are more expensive, when you look at it globally in terms of the economy, these are people who will pay taxes to the economy. Then, of course, you build your skill and expertise as a country. So there is a value in as much as probably the end commodity may not be as cheap as you'd expect. And therefore, even in this case, quite a significant significant proportion, I think almost half, if I'm not wrong, or 40% of the commodities were declared that they have to be from locally manufactured. Then looking at digitization. Digitization takes away inefficiencies. What do we need? As we think of increasing our domestic financing for health, inefficiency is one of the way of actually increasing domestic resources through efficiency gains, working around the inefficiencies. And one way of handling inefficiencies is through digitization. Then we have the human resource for health. Just seeing how can we realign the human resource for health. At the end of the day, health is a social sector, just like the police. Our greatest asset is not even the equipment and the hospitals. Our greatest asset are the people. So just seeing how we have adequate staff, who are well trained, and they are well distributed, because we all know Nairobi has like all the specialists. But then, so in terms of numbers, if Kenya is asked, do you have a good number of this and that specialist, will say yes. But then they're only concentrated in one region. So we're talking about not only the skill mix, the numbers, but also the distribution. Then finally, just looking around the primary healthcare approach. It's well known, these days we quote this a lot, that investing in primary healthcare gives you a return on investment of $1 in $16. And therefore, we are still focusing on primary healthcare. We may not see the results this year or next year, because right now there are already people who are sick. Maybe people already have cancers, they already have diabetes, hypertension, because probably they, for one reason or the other, either, the reasons behind some of them could just be around their lifestyle diseases.
Exactly.
So those ones will still be there, so we'll keep on managing them. But we need to close the tap. We need to prevent more from getting into that pool of diabetes, hypertension, and other non-communicable diseases. For instance, the cancers. We know when you get hold of a cancer early, even the treatment is cheaper. So what I'm trying to say is that those are actually financing mechanisms, because if I end up spending less on managing early cancers, then I don't need to spend more on more complicated ones that have been detected late. So, and that's why I brought all these aspects and said that all of this actually relate to financing. So you couldn't do one without the other. You couldn't say that this first 5 years we only want to deal with primary health. What will happen to those who already need the service? What will happen to the human resource? Do you have the adequate human resource for the primary health itself? And then as we progressively move, we'll touch on things around quality, because the first thing is to access. Then just look at how can you keep improving, because quality is progressive. You can never say that you have reached the maximum. There's always another opportunity to do something better.
Exactly.
Yeah.
All right. Thank you so much for that response. And indeed, you've touched on a lot of things which are really pertinent. The political commitment, as you said, because UHC requires a lot of political commitment to achieve, and as you said, is a journey. And particularly when you talked about the primary health care, I've seen the president even commissioning the community health promoters and making a commitment towards supporting that, because they are within the communities. They can play a big role in the preventive and promotive aspect, which sometimes is overlooked as we are funding. Now, perhaps then to drill a little bit deeper, because there are pieces of legislation which have been passed to operationalize these. And the word in most Kenyans' mouths is around SHIF, and the shift from NHIF, which we've known, to SHIF, Social Health Insurance Fund. And I know there are also other funds which are within that same bucket, which the ministry is putting together or coordinating. So would you mind to talk very briefly about the four aspects which are covered by what the government is doing right now in reforms?
Yeah, so just to ride on to my previous point on the pillars, the pillars under the bottom-up agenda for health. When you look at the primary health intervention, it is supported by the Primary Healthcare Act. Okay. And the reason why we could do a Primary Healthcare Act is because we already had the policy documents in place. So during the last administration, when we had the Big Four agenda, actually the main focus, apart from the fact that it was input-based financing, was also to set up the foundational documents. So we had the PHC. During that time, we came up with the PHC strategic framework, the one in a kind. Many countries have come to just see how did we come up with this PHC strategic framework. We have the community health policy and strategy, and all this were put together to support the Primary Healthcare Act, because an act must be based on an existing policy. Then we have the Digital Health Act, which rides onto the digital agenda. Yeah, we have the digital agenda with a focus on, creating what we call a digital superhighway for the entire health sector. I know right now the focus has been on SHA, but the digital superhighway is something that will serve the entire health sector. SHA will just be a component of it. Then we have the Facility Improvement Financing Act. That one is mainly for public health facilities, and it's in the realization that at county level, or I would say call it at subnational level, health has been seen as a generator of income for other priorities apart from health. So, and yet health itself doesn't have enough resources. So this act came in place to actually ring fence the resources collected at facility level and give the facility the autonomy. You can ring fence, but don't give the autonomy. So you have just ring fence, but someone will just tell you, give us your ring fence resources.
Sure.
Yeah, so it not only provides for ring fencing, but also for the autonomy at facility level. Then the Social Health Insurance Act, which is called SHIA, the SHIA or the SHI Act, which established the Social Health Authority. So the Social Health Authority is what replaced NHIF, just like Kenya Revenue Authority. So it's an authority that replaced NHIF. And this one has 3 funds. So we have the Primary Healthcare Fund, for primary services at health facility level. Then we have the Social Health Insurance Fund, and the Primary Healthcare Fund is publicly financed. So taxes and donors are also allowed to finance philanthropies. You can also support the Primary Healthcare Fund as a person. Then we have the Social Health Insurance Fund, which is contributory, and that's where we have all citizens contributing 2.75% of their household income. For the ones in their salary, who are salaried, 2.75% of their gross income. No matching fund from the employers. Then for the informal sector, who are the largest proportion, close to 80% of the population, it's also 2.75% of their income as determined by the means testing. So the challenge that we'll just face there is how do we really reach all these people in the informal sector? Then we have the Emergency, Chronic and Critical Illness Fund. Despite the fact that emergency care is outlined in our constitution, that you cannot deny anyone emergency medical services, this is one aspect of the constitution that had never been operationalized. And therefore, through this act, we will operationalize that, where we have this fund that will cater for emergencies, irrespective of whether you are a member or not. Sure. So, any emergency, there are those conditions considered emergencies, then they'll be addressed at whichever facility. And it doesn't matter whether the facility has been contracted or not. Every facility has that obligation to offer emergency services. Then we have the Chronic and Critical Illness component of that fund, whose main mandate is to cater for, those conditions. First of all, for you to access the Chronic and Critical Illness component, you need to be a paid-up member of SHIF. So this one mainly caters for conditions or limits that have gone way beyond what is captured within the SHIF. So, for instance, if we are saying ICU, the limit for SHIF under ICU care is 7 days. and probably you have been admitted for 20 days. Those extra 13 days will be charged under the chronic and critical illness. So you just look at benefit by benefit, because that is how the SHA benefits are structured. It's not like the private insurance, probably, where they tell you your limit is 2 million. Here we have limits per package. So your other package may not, you may not have exceeded your limit, but for this specific package, say ICU care, you have exceeded, then that particular bit gets charged onto the ECCIF, and this one is also publicly financed. So I would say that Kenya has, when you look at this financing for social health insurance, it's mixed. It's both tax funded and contributory, because of the two funds. The two funds are actually publicly financed. It's only the SHIF that is contributory.
Thank you so much for actually demystifying that and talking about the benefits. And part of this is also to counter any disinformation and misinformation that may be there in the public. So thank you for delving deep into what it means. And I know the focus perhaps has been the implication in terms of the contribution. So people also understanding also the benefits that are going to accrue from that is really important. But you've talked about a very important thing, and you've alluded to the informal sector. And as you said, the fiscal space is constrained. If you look at Kenya, a large percentage of the people who are earning are actually within the informal sector. And it's been a bit of challenge to bring them into that contribution. I've had conversations with the prior senior leadership of NHIF where the same was attempted. And I remember there was a legislation which was passed in 2022 to sort of mandate the contributions from the informal sector. I don't know about the enforcement of that. So for me, I see an opportunity there because obviously this is a very ambitious plan that the government has. So I would like to hear from you on perhaps what the government is doing to make sure that we bring also beyond those who are formally employed, where it's much easier to get those contributions, what you're doing to also bring the informal sector into the contribution.
Yeah, so the Act actually tried to bring that. If you look at Section 26.5, really mandating all Kenyans to contribute, and the main article there, or the main aspect there, was around people not being able to seek government services unless they show that they're actually members of the social health insurance. So that means that for you to renew your license, for you to renew your business permit, for you to get services at Huduma Center, whichever services, you needed to first show that you are a member of the Social Health Authority. Now, this particular section was contested in court. We are still appealing, but as we appeal, we are still thinking of then what are our next strategies. Number one is focus on the benefit, because I believe, and we have seen from the Gen Z movement, that people are willing to contribute if they believe in the cause. If we are able to sell the benefits and tell them these benefits, for sure, if you go to this facility, you'll get these benefits. And probably bring in even people who have benefited, like, the beneficiaries, maybe someone who has undergone a surgery and NHIF has paid for them, maybe a cancer patient, a dialysis patient, then they become our advocates and actually make people, they can actually get people, on board. The other aspect we are looking at, just riding on to the previous point of advocates, is how can we get champions? Because just looking at who are influencers in the community, opinion shapers, and who can be our champions. Then just looking at where are these informal sector people placed. These informal sector people are in places like circles. Boda Sacco. I don't know that there's Mama Mboga Sacco maybe, but they are in all these, SACCOs and MSMEs. So just seeing how we can work with those. We have been engaging actually the SACCOs and cooperatives to see how they can even convince their members to be part of it. And the good thing about some of these SACCOs and cooperatives is for those, I would say for the, for the informal sector, like let me give an example, like the farmers. We know that they may not have their resources immediately, but when they get their harvest, when their cow delivers or when their tea is harvested, they take it to the cooperative and they are given of course they have now their resources there. So just had those discussions, seeing how can we tap into that and have them even have the SACCOs pay for their members, some of their members. Then as they bring in their produce, this is deducted because it will happen at some point in the year. But in the meantime, all this will be catered for. So these are some of the approaches we are trying to use to reach the informal sector. We are sure it won't be easy. And that's why, given that the difficulty in getting to the informal sector, the law actually mandates them to pay for a year, because you'd rather wait for a year than keep chasing 80% of 55 million Kenyans every month, to see whether they have paid. Because people may register, they may pay for a month or two, but they won't retain. They won't. That consistency.
In fact, that's the main problem or issue which had been highlighted when I last spoke to the NHIF senior leadership about adverse selection. So people just making the payments when they know they need the service, and once that need is over, then the consistency is not there. Yet the funding needs to be consistent. So thank you for speaking to that. Perhaps maybe segueing into another issue that you spoke to, which is the human resources for health, a really critical component of health services delivery. And I know in Kenya we've had our own challenges, fair share of challenges, including the deployment of interns, which caused a bit of an issue. The pay, the agitation for better pay within those who are employed within the public sector. And I know we are juxtaposing these against where we have fiscal constraints. You talked about the loans that obviously we've accrued, and meaning that we are a lot of our revenue which is being collected is also going into repaying those loans. So I don't know what your perspective is in terms of how we can address this, and also the over-concentration within the urban areas, meaning that there are areas which are significantly underserved. So I would like to hear from you, our audience would like to hear from you about what the government is doing around funding so that we can facilitate the human resources for health, which is really critical.
Yeah, this is quite a critical component, as I indicated, and it can actually make and break all our initiatives within UHC. Because right now, if the doctors or the nurses decide to go on strike, we cannot even launch UHC in October. So when I think of human resource, I look at it right from production. And that's where the issues even of interns come in. Remember, the production is not done by the Ministry of Health. The production is done by the Ministry of Education. The production is not a Kenyan production. When you train people, they are not training them for the Kenyan market. You're training them for an international market, a global market. So it becomes difficult to limit the training if they have the slots, because you're not just training for Kenya. I may want to finish my training and go, out of the country. But then there has to be a clear policy around, after that training, then what? Who takes up the responsibility of of the interns? Because if the government, and that's where the ministry he's now working in consultation with the Ministry of Education. We can look at it in a way that we say, okay, if you're government sponsor, that means us as a government, we know you. We know you, and that means we can plan for you. Because right now, so many, previously you'd find almost only 400 intern doctors graduating in a year, but now they are over 1,000. And you see, as they train them, there's no communication to the ministry saying that now we are training 1,000, start preparing your budgets. We know government. Yeah. You have to budget.
True.
You have to budget. So that's where the challenge is. So the whole point is either you reduce the amount and pay everyone, or you only pay for those whom you know, because you paid for they were government sponsored in the first place. So that is one approach. Of course, it will be met by resistance. We'll be told we're discriminating and all that. So there is no, you are doomed if you do, you are doomed if you don't. But there needs to be a clear policy around that production. And the production goes hand in hand with the capacity even of the hospitals in the attached to the university. Right now, if you go to some of our training centers, you'd find medical students, from the university. You'll get students from KMTC of different cadres, nurses, clinical officers, all of them going for what you call a ward round. So you're a patient there, and you get this whole group of people, over 50 people, surrounding you, listening to what your problem is. And the person at the back is really not getting what the person at the front is saying. So what quality? So I think as the Ministry of Health, where we come in is to say, if you are a training hospital, you can only take this number of people. Therefore, if the university wants to train more, they look for other facilities where they'll be taking their students so that they get the exposure in the wards. That one could work in terms of even the quality. Now, once you get into the ones in service, distribution, you said very well, around issues around distribution. And sometimes there's a justifiable reason why someone is somewhere, maybe family, maybe health conditions and all that, but it can't be the norm for everyone. So look, just having a policy around distribution, and also around making maximum use of the time of these clinicians, because you'd find in some public hospitals, someone, especially maybe a consultant, they are allowed, yes, to do their private practice, but then if you compare the amount they spend in the private practice vis-a-vis in the primary facility, it's very small, and therefore it creates a pseudo shortage. Yes, so if we can work around that, just seeing how can these practitioners, give their maximum required hours. I always strongly believe, because it doesn't happen, that we may not need as many doctors or even nurses or even clinicians than we claim we need, because shifts will be covered, and these practitioners will be on the ground. Embracing innovation such as telemedicine. I may not need to, not all counties may need, for instance, to employ a radiologist. You just need maybe one in a central area, or a group in a central area who will be doing, like reporting. Therefore, you save actually, you eventually save. So, and of course, the fact that we are in a devolved setting makes things even more complicated. Because once you find yourself in a county, you are locked there for life, because that is your employer. And yet some of these specialists, especially when you're looking at the specialists, these specialists need to move, around. You may be in a county that doesn't have I may be a cardiothoracic surgeon or a neurosurgeon, but if I limit myself to the county where I'm employed, I may not get the numbers. Yeah. And therefore, the experience, the more you do something, in medicine, the more, like when I was in Pumwani, I worked in Pumwani. Because of the many mothers, we used to do cesarean section in 15 minutes. while probably someone somewhere will be doing in an hour. For us, in 15 minutes, mother in, mother out. Because of not just the volumes, but because of the experience.
True.
Yeah, so human resource is not a very small issue. No wonder the president set up a presidential task force to look into that. Because, as I said, no real intervention will seem very favorable. True. There'll be someone who will feel aggrieved, irrespective of whatever you say or whatever you do.
No, you're right. You're right about that, and I guess there's a lot that needs to be done around that area. And you've actually alluded to the fact that the health sector being a devolved sector, the county governments also have a role to play. If they can enhance also their revenue collection, then they're able to dedicate some bit of funding to also absorb some of these professionals who are available. All right. Perhaps let's segue into something as we head to the end around the role of now non-state actors. I know we've focused a lot on what the ministry is doing, but I think also the non-state actors also complement what the government is doing. And in this case, we have faith-based organizations, NGOs. We also have the funders, the bilaterals and the multilaterals, and also the private sector, which also caters for a bit of the provision. So I'd like to hear perhaps from you on some of the interesting things and collaborations that you're having with these non-state actors as far as funding, financing healthcare is concerned.
Yeah, so talking about the non-state actors, I would start even with the civil society. One of their key role, even as civil society, apart from accountability, is advocacy. Mm-hmm. They can make noise so long as they are with you on your side. So when I look at what will be their role, it will be for them to be our advocates, send this message out. And also, as they advocate, they'll also hold us accountable, and therefore, if the civil society are comfortable and say, I think they are doing their work, accountability is good, then the general population gets that confidence, because right now there's a lot of mistrust with government. Mm-hmm. Then, so they can be our advocates. Then just looking at the private sector, tapping into the strengths within the private sector, efficiency. If there's something about the private sector, it's efficiency. Sure. Many people who leave the private sector and come to government, it's usually culture shock. Many of them say, bureaucracy is what, but for us, it's normal. But just tapping into the efficiency within the private sector can really, really, really help. For the, donors, the bilaterals, multilaterals, aligning to our priorities, just seeing how can they align to our priorities and invest in our priorities and not their priorities. Mm-hmm. We know partners who come with their priorities and want to push it down our throats.
Sure.
And therefore, ours is to say, how can they come in together, align with our priorities and support us so that we achieve our goal as outlined in our, in our policy documents.
Okay, right. And I guess that, donors and funders and others contributing it to the national plan is really critical. It's part of what the Lusaka agenda actually talks about, better coordination of the resources. Now, you've talked about the private sector. Just allow me to mention about some of the initiatives around public-private partnerships, because that's another avenue. I was attending the other day an event by the American Chamber of Commerce, where they were talking about where are the opportunities for the private sector to work with government. One of the notable projects, obviously, is the managed equipment services through the previous administration, which sought to make available different equipment, diagnostics, and all these in facilities, public facilities, without having to procure, so not having the upfront cost. That has been talked about in different forums. I've attended international forums where that's highly talked about. I don't know in the current administration whether there is any plan to tap into such sort of arrangement. I'm seeing it happening in other sectors, in transportation, in housing. I don't know whether within the health sector there is a plan to tap into the private sector in that sense.
Yeah, so number one way in which we have tapped into the private sector is through the digitization. We know that we are working closely with Safaricom to come up with the entire digital superhighway. But above all else, they are just as a successor to the managed equipment service. We are having what you call the National Equipment Support Program. National Equipment Support Program will have a more or less arrangement. It's just that for this program, there'll be no upfront, the financing arrangements are a little bit different. So we have areas where we have like what we call framework agreements, especially for the equipment at primary level, where you look for a suitable, we look at the framework agreement as outlined in the public Procurement Act, the Procurement Act. You have a pool of vendors who can be called upon. So you negotiate with them a price and tell them within this period of time, it's usually around 3 years, not more than 3 years, I think, for the framework agreements. If you are called upon by this and that county, you should supply them this equipment. And sometimes even with such arrangements, you can even go further and request them to support, and then have flexible payment plans. Yeah, so that actually spreads, it eases the pressure at the instance. And the service will get, of course, the patient will get the service because the equipment will be on the ground. But then your payment is not, instant. Yeah, it's not immediate. Then we have things like placement. Where private sector can go and actually place an equipment, and the only way they get their resources is through purchase of, say, reagents. Just the way in most of these developed countries they give you a free phone, but you have to keep paying for the plans.
True.
But you see, at that point, you don't have to invest in the latest iPhone. Then there are arrangements like fee for service, where actually a private entity can come and set up shop in your facility.
I see.
Because either way, they're just outside your facility. The patients are crossing the road.
Yeah.
So why can't they be in? And actually, as they do their business, you have a memorandum of understanding on how you as a facility, you can make the money. What that means is you as a facility, even the perception to the public is that if you go to this facility, you'll have this test done, this X-ray or this lab test, done. You don't know about the back end payment arrangement. So generally, and I like giving the example of a mall and a supermarket. Any mall whose supermarket falls, the mall dies. True. Why? Because the main reason why people go to the mall is the supermarket, then they'll go to the shop, shops around. So even for this equipment, say even if it's an X-ray or a radiological equipment or a lab equipment, if it's placed in the facility, people will know if I go there, I'll get this service, and therefore I can also tap into other services that the facility is actually offering. So we are looking at such opportunities, and these discussions are even at an advanced stage, and probably at some point this year, this will come to pass. It's a discussion that was actually discussed at the summit with the governors and His Excellency the President, where it was agreed that the counties, if their equipment, will contribute 30%. If a county requires equipment, they just need to raise 30%, and the national government pays 70%. So with that, it will encourage, for the counties who want this equipment, it will encourage them to join into the plan so that they can take advantage of these additional resources.
Wow, Wow. Sounds very exciting and looking forward to that. So perhaps now bringing it all together, there's something you said which was very profound about whether, I know we've been talking about the money, the funding, where do we get this funding? But one of the aspects which was also discussed again at the national high-level dialogue on health financing, which I believe the Ministry of Health sort of hosted, was around how do you get more health for the money? Not just more money for health, but more health for the money. What do you think is happening right now in terms of realizing that, getting more health for the money? You talked about some of the indicators which are lagging. So where do you see us going as a country in terms of getting more health for the funding that is available?
Yeah, so with that, a lot of it is still around efficiency, because we have this money, we have 500 billion. Yeah. How do we make sure this 500 billion moves a needle? Basically, that's what we are talking about. And it all aligns with the prioritization, putting the money where it matters, pooling of the resources, from different places towards a common plan, a common budget, a common M&D. So that's how you'll end up getting more health out of the money. So you may not necessarily even need to invest more. You just need to realign, reduce the leakages of resources, and eventually get the result. The other one is, even as I said before, around primary health. When you invest in the same resources, if you put them into primary health and people are more healthy, then you'll get actually more health out of that same money. Instead of always paying for, sick care, you are now paying for healthy care.
Yeah.
Yes.
Thank you so much for that. Right now, as we come to the end now, these are platforms where you can also pass some messages to Kenyans from your perspective, working with the Ministry of Health. So I'll hand it to you to have a parting shot in terms of what message you'd like to pass across to Kenyans.
Yeah, so I think one of my greatest message is still that UHC is not a destination. It is a journey. And for every journey, every part of the journey, there is learning, relearning, adapting, changing. And if we, trip, we wake up, dust ourselves, and say we have learned from that trip. Next time we won't use this route. We'll try and deviate a bit, and we keep improving. The other thing is that without data is really key. Without data, it's very difficult to really know whether we are making any significant difference. And therefore, just looking at how can even the population engage in some of these reports that we give. They look at the data and hold us accountable. We know that the Control of Budget publishes reports on a quarterly basis. How many Kenyans actually go there to see how are the counties spending? How is the national spending? Hold us accountable. But at the end of the day, for us to achieve UHC, let us work together. Let us work together and keep healthy. At the end of the day, we really want to sell or focus on primary health.
True.
And primary health is the responsibility of you and me. And I always remember what the former CS Kagwe said, that he at some point when he said, okay, now the masks, there's no more COVID. But it's up to you. You need to take care of yourself.
Exactly.
Yeah. So at the end of the day, from within primary healthcare, the responsibility lies upon you. If you need to eat healthy, if you need to exercise, have a healthy environment, clean environment, sanitation, those are things that you shouldn't wait for government. You should be able to do that as an individual.
Certainly. And I'll be sure to meet you at the hiking trail, as you said, because I also need to keep healthy. Thank you so much, Dr. Wangia. This has been a real pleasure. Thank you for sharing those insights with our audience. And we certainly look forward to some of those things that you said are in the pipeline, and obviously supporting the national government, the county government, and all others in realizing the UHC agenda that we have for the country. Thank you so much for being our guest today.
Thank you so much also for inviting me.
We appreciate your time and hope you found our conversation insightful. Be sure to follow us for more thought-provoking insights.